Hey there, future coding pros, and welcome. Today, we're going to crack the code on a set of CPT codes that can be a real head-scratcher when you're starting out, 20700 through 20705. These all have to do with special drug delivery devices, and I promise by the end of this, you're going to feel way more confident navigating them.
So here's our game plan. We're going to start with the absolute foundation, a concept called manual preparation. Then, we'll walk through how you code for putting these devices in, and then how you code for taking them out. And to wrap it all up, we'll go over the golden rules you absolutely have to know.
All right, let's start at the very beginning. Seriously, understanding this one term, manual preparation, is the key to everything. Once you get this, the logic behind this whole set of codes is just going to click into place.
So what is manual preparation? Well, the key word here is manual. This isn't some pre-packaged device that comes out of a box. This is something the surgeon is creating, by hand, right there in the operating room. They're making a custom little device specifically to fight a really nasty infection deep inside the body.
And this is what it looks like in action. You'll see in the op report that the surgeon is 1. Mixing the antibiotics. 2. They're combining it with a carrier material, usually a type of bone cement. 3. They're physically shaping that mixture into beads or a spacer. And 4. They're placing it right at the site of the infection. All 4 of these things have to happen for it to count.
Now here's a crucial point, probably one of the most important. These codes, 20700 through 20705, are add-on codes. I want you to think of them like Robin to Batman. Robin's great, but he can't carry a movie on his own, right? He's always with Batman. Same thing here. These codes can never be reported by themselves. They're always added on to a primary, bigger surgical procedure.
Okay, moving on to section 2. Let's talk about coding for the insertion of the device. The big clue here, the reason you'd even be looking at these codes, is infection. The surgeon is doing this because there's an active infection, they suspect one is brewing, or they're trying to prevent one from starting.
So the code set is really split into 2 families. You've got your insertion codes. Those are the ones ending in 0, 2, and 4. You use those when the infection is the main problem. Then you have the removal codes, ending in 1, 3, and 5. Those are for later, usually after the infection is gone. But look, they're both still add-on codes.
All right, so how do you pick the right insertion code? Well, it's all about location, location, location. It's actually pretty straightforward. If the device is placed deep in the soft tissue, you're going to use 20700. If it's placed inside the bone, that's intramedullary, you'll use 20702. And if it goes right inside a joint, intra-articular, you're looking at 20704.
Okay, a few really important watch-outs for you here. First, you only report these codes once per location. Second, and this is a big one, you do not use these codes if the surgeon just uses antibiotic cement to glue an implant in place. That's called fixation, and it's totally different. And finally, some big procedures already include placing a spacer in the code description, so you can't add these codes on top. That'd be like billing twice for the same work.
Let me just say that again, because this is probably the #1 mistake people make. If you read in the op report that antibiotic cement was used, but it was just to secure a new hip joint or something, that is not manual preparation. You do not use these codes. The cement has to be its own thing, a device made to deliver drugs.
All right, let's fast forward a few weeks or months. The device has done its job, the infection is hopefully gone, and now it's time for the patient's next chapter, getting the device removed. And, you guessed it, the coding has its own special set of rules.
So let's imagine the best case scenario, right? The patient comes back for their second surgery, and the news is great. The infection is totally gone. How does that change how we think about the coding?
Well, the whole story of the operation changes. The main goal isn't fighting infection anymore. It's about rebuilding. It's about repair. So your primary code, your Batman, is going to be a code for a reconstruction or a complex closure or some other kind of repair procedure. The device removal is just the add-on, the Robin.
Okay, but what about the flip side? What if the surgeon goes in to take the device out and, uh-oh, the infection is still there? How does that plot twist change our codes?
If that infection is still hanging around, the mission changes completely. The #1 priority now is to clean it all out. And the medical term for that is debridement, which is just the removal of all that infected and damaged tissue. So, in this case, debridement becomes your primary code, and the device removal code gets added onto that.
And this table is an awesome cheat sheet for that logic. Just look down the columns. Whether it's bone, a joint, or deep tissue, if the infection is still there, your primary code is some kind of debridement. If the infection is gone and they're rebuilding, your primary code is for reconstruction. This is a great little table to have handy when you're studying.
Now, one last little curveball. What if the only thing the surgeon does is take out the device? No debridement, no reconstruction, literally just in and out to remove the beads or spacer. In that very specific situation, you don't use the 2701, 3, or 5 codes at all. You use a totally different code, 20680, which is for removing deep hardware.
Whew, okay, we have covered a lot of ground. So let's boil this all down into our final section, the golden rules. This is your cheat sheet, the stuff you absolutely have to remember for your exams and for your career.
Here we go. Number 1, they are always add-on codes. 2, only report them once per location. 3, never ever use them for pre-made off-the-shelf devices. 4, if removal is the only thing that happens, you use 20680. And 5, the most important rule of all, the status of the infection. Is it there or is it gone? That is what drives your choice for the primary code.
If you remember just one thing from our time together, let it be this. The story of the infection dictates the story of the code. Is the surgeon fighting a war against an active infection, or are they rebuilding after the war has been won? The answer to that question tells you exactly how to approach the coding.
So, I'll leave you with this final thought. You now know the why behind these codes. Your next step is to get really good at the how. How can you scan through a surgeon's operative report and spot those keywords and clues that point you to the right code every single time? Keep practicing. You're going to get it. Thanks so much for joining me.